PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. Today's program is part of our PD Health at Home virtual program series. Each week, we offer sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, Fitness Fridays, care partner programs, and expert briefings. We also have our Spanish language series, EP Salud en Casa. If you speak Spanish or know of anyone who might be interested, next month's topic will also be on falls. Just visit parkinson.org/epsalud. And for more information on our PD Health at Home series, visit parkinson.org/pdhealth. On to today's program. Falls are a common concern for people living with Parkinson's and can have a significant impact on safety, confidence, and independence. Today, we'll explore how Parkinson's affects gait and balance, common factors that might contribute to falls, and ways to recognize early signs of fall risk. We touched on this topic last year with one of our presenters we'll hear from today, but we wanted to go a little bit further. Looking at surveys and follow-up questions that came up from that webinar, we wanted to make sure that we went deeper in really talking about how to fall safely. This also ties in from feedback from a person with Parkinson's, Douglas Prop, who provided valuable feedback in shaping today's webinar. During today's presentations, please feel free to submit your questions at any time using the Q&A button on your screen. We'll have time towards the end to answer as many as we can. First, we'll hear from Dr. Mitra Afshari, a fellowship-trained movement disorders and deep brain stimulation specialist practicing in Chicago with special research interests in gait, balance, and falls in Parkinson's disease. Afterward, we'll hear from Dr. Miriam Rafferty, Director of Implementation Science and a Parkinson's physical therapist at the Shirley Ryan Ability Lab. Her research focuses on rehabilitation service delivery for people with Parkinson's, particularly examining how proactive rehabilitation can facilitate long-term community exercise participation. Thank you so much, Dr. Afshari and Dr. Rafferty, for joining us today. Feel free to start your screen share, Dr. Afshari.
You got it. Thank you so much for that kind introduction. Here we go. Does that look okay?
It looks good. Thank you.
Beautiful. Thank you for having me here, Danielle, and everyone. As Danielle mentioned, we did a talk close to a year ago about gait and balance in Parkinson's disease. Got some wonderful feedback from the audience, and I think you'll all be very pleased as we've incorporated that feedback into this presentation. And we have a lovely video at the end of the presentation, so I hope you stick around at the end on how you can fall more safely, because falls, as Danielle mentioned, are inevitable, unfortunately, in Parkinson's disease. So these are my disclosures. As Danielle mentioned, I've done some research in fall prevention, and these have been some of my sources of funding. Here are our learning objectives for today. We'll learn how Parkinson's disease affects gait, balance, and movement, understand common signs and symptoms of changes in gait and balance, explore strategies and safety precautions to reduce fall risk and improve your safety during falls. And we'll talk, my wonderful colleague here, Dr. Rafferty, will talk about treatment options, especially rehabilitation therapies and exercise programs that can support fall risk reduction. When Miriam and I were putting this presentation together, we wanted to split the presentation up into 3 parts. So we've focused the different objectives into these 3. So essentially, we're going to understand the multiple factors affecting gait and balance and fall risk in Parkinson's disease. I'll be going over that portion of the presentation. Dr. Rafferty is going to focus on the evidence base approaches and rehabilitation strategies to improve fall risk, as I mentioned. And then we're going to end the presentation with the video that I mentioned on how you can fall more safely, and how you can get up from falls more safely. We've created this video in partnership with a wonderful physical therapist through the Shirley Ryan Ability Lab named Jennifer Barber. And so I'm going to jump right in to the first part of this presentation. First and foremost, I'd like to mention from my experience of discussing dozens and dozens of falls with my patients, I really have discovered that falls in Parkinson's disease are almost always multifactorial. So, of course, with a condition like Parkinson's disease that primarily affects mobility and movement, there are internal factors that contribute to falls, and we'll discuss those in the next few slides. But oftentimes there's also external factors that surround those internal factors and increase fall risk. And a lot of my research in this area is addressing both of those factors, especially in the home where most falls are occurring. And so it's important to take both of these factors into consideration if you really want to make an impact on reducing your fall risk as a Parkinson's disease patient and as a care partner of a Parkinson's disease patient. So pictured here, as you see pictured here, you need to be equipped with kind of multiple arrows in order to really hit the target when it comes to falls. Now, what fuels those internal or inherent factors that affect gait and balance and increase your internal fall risk? Let's start with the basics. What is gait and balance? So we use these words in our clinic visits a lot, and we want to make sure that you truly understand what gait and balance is. When I was putting this presentation together, I thought it would be helpful to use an analogy. And so you can think of gait and balance a little bit like a running car. So gait, or sometimes we call it locomotion, is the forward motion of the car, which requires that the wheels work in tandem, that there's some automaticity, and that they work with a rhythm. And what balance is essentially the stability of the car that really allows it to stay on track and to correct for outside or external perturbations that might throw it off course. And so when any of one of these gets disturbed, the car can either stall, which means that you can't get the car started or you can't get the car restarted. Might also call that kind of an ignition failure. That's akin to a motor block in Parkinson's disease. Or unfortunately, there can also be a crash. And that, from my perspective, is kind of akin to falls in Parkinson's disease. And unfortunately, as you know, falls are currently the leading cause of morbidity and hospitalization in Parkinson's disease. Let's talk a little bit more about the impact of falls. So unfortunately, 60% of all people with Parkinson's disease, that's the acronym here, PWPs, fall once within a year. And as your disease advances, those falls become more common. 39% of all PWPs fall recurrently within a year. And those consequences are quite grave. As you can imagine, falls result in injury and fractures, with hip fractures being the most common. Because of those injuries and fractures, this results in secondary immobility, and that secondary immobility has its own consequences of muscle wasting and further weakness that affects ability to continue to move. Falls obviously reduce quality of life and independence. And unfortunately, many falls oftentimes ultimately result in nursing home placement, at least if not temporarily, but also permanently for many patients, because it becomes risky if a patient is having such frequent falls and needs constant supervision. One really important fact about falls in Parkinson's disease, and this has been documented in the research, is that most falls in Parkinson's disease occur in the home. And this becomes especially relevant when you're talking about those external environmental factors that increase your fall risk, which I'll touch upon in the next few slides as well. What can affect these two elements, gait and balance, in Parkinson's disease, which can ultimately lead to the car stalling or the car crashing? And from my perspective, there's two issues here. There can be continuous issues that can affect gait and balance, and there can be episodic issues that affect gait and balance. You can think of the continuous issues as affecting the car while it's driving. Some of those issues include the slowness of the pace, the slowness of the gait, which is the pace of the walking. In Parkinson's disease, you can have what's called a shuffling gait. And what that really means is that the steps are short and small. You can also have variability in your steppage. And more often than not, there's asymmetry when it comes to Parkinson's disease. You may remember that your Parkinson's disease often starts on one side of the body. And so one foot may be lagging behind the other, and that can result in issues with gait and balance. Another common feature of Parkinson's disease is dystonia or dyskinesia. One of the more common dystonias that our PD patients experience is the foot turning in or the toes curling or even one of the toes going up, and that often is related to medication fluctuations. Those too can affect gait and balance. PD patients tend to take on a stooped posture, which changes the center of gravity. Arm swing is actually important to locomotion as well. And so PD patients, because of rigidity, also have reduced arm swing. And then finally, one important feature that can be continuous as well is that a lot of PD patients, after they've had their first fall, there can be a significant fear of falling, and that anxiety comes into play and can make matters worse. And then there are the episodic issues. This can be akin to when the car is starting or turning or stopping. And these episodic issues can be kind of mysterious sometimes and confusing. One of the most common ones is freezing of gait or fog. Freezing of gait especially occurs during initiation of gait, during turning, going through thresholds, and during stopping. And I'll show you some videos that demonstrates that in a future slide. There is also an episodic gait disturbance in Parkinson's disease called festination, which is essentially a cousin or sister to freezing of gait, where there's an element of freezing and also the center of gravity, the upper body being forward. And so a patient can kind of propel forward with their upper body in the setting of a freeze. There can also be transient loss of postural instability. We sometimes call that retropulsion. And this can result in a sudden fall backwards. Why do these issues occur in Parkinson's disease? So in Parkinson's disease, as you know, one of the main issues is a low dopamine state. And what this low dopamine state causes is these first three cardinal symptoms of Parkinson's disease. There's bradykinesia, which is progressively smaller movements. There's rigidity or stiffness. That stiffness can manifest in the spine and the trunk. It manifests in the extremities. It causes that reduced arm swing. And overall, that rigidity manifests as a less fluidity when it comes to walking. And then there's postural instability, which is that propensity to fall backwards. So these three symptoms are actually how we define Parkinson's disease. And these are the main symptoms that manifest during gait and balance and can result in falls in Parkinson's disease. And ultimately, dopamine acts on these deep structures of the brain called the basal ganglia. And the basal ganglia is really what drives gait automaticity, what makes walking automatic. And so in Parkinson's disease, you have a loss of that gait automaticity. And over time, with advancing disease, you also have a loss of your helping hands. So that's what I've kind of tried to demonstrate here is oftentimes we can use the rest of our brain to compensate for that loss of gait automaticity. And that's our higher level brain, which is the cortex, the coverings of the brain. And over time, unfortunately, when Parkinson's disease advances, we lose those compensatory strategies as well. As we move on to a discussion of those external factors that contribute to falls, it's really important for us to focus and discuss and make sure you understand freezing of gait, because as this is so common in patients with Parkinson's disease, it's important for you to recognize it so that you can have a comprehensive and meaningful conversation with your provider about freezing of gait if this is what you're experiencing. Freezing of gait affects 50% of all persons with Parkinson's disease, and in advanced Parkinson's disease, it affects 80% of patients. And research studies have shown actually 61 to 69% of falls in persons with Parkinson's disease is attributed to freezing of gait. As I mentioned before, it's again an episodic issue that occurs, so it's often kind of confusing for patients and providers alike. And so I wanted to take this opportunity to really go over freezing of gait with you as well. And I know in future slides when Miriam is able to present rehabilitative strategies to help, some of this will be revisited. So freezing of gait being a major contributor to falls, by definition, is a brief episodic absence or marked reduction of forward progression of the feet despite the intention to walk. What does that mean? It essentially, a lot of people describe it as the feet feeling glued to the ground. This can manifest as start hesitations, essentially a motor block upon initiating gait. And it can also manifest as arrest during walking, so stuttering steps and also pure motor blocks. And I wanted to show a video example of freezing of gait to you. So this patient is going to be experiencing some freezing as he approaches that gray area on the floor. You can see he's having these stuttering steps, and potentially his right foot is having a little bit more freezing than the left foot. It's really feeling getting glued to the ground. Now he's attempting to turn, and you can see that right foot, both of them actually, but that right foot especially is really kind of glued to the ground. And that's most likely where his Parkinson's started, was on that right body. And so he's really, this is definitely a freezing episode you could see, and he had another freezing episode before he turned on that gray area on the ground. Now, in this video, he's approaching a threshold specifically. And as he's approaching that threshold, he's having a freeze. Our feet are stuck to the ground. And so this is a really nice video of freezing of gait. I'm sorry. So another important thing to keep in mind with freezing of gait, and this is one of the reasons I wanted to talk about this, was when I'm focusing on the external factors that contribute to falls. Freezing of gait specifically is precipitated and relieved by these external factors. So it's precipitated by circumstances that essentially challenge the gait, and also circumstances that require small steps. And so these are the circumstances that you saw in this video: turning, approaching thresholds, tight spaces, obstacles, change in the floor pattern, which we saw in the video, and also doing two things at once. We call this dual tasking. But keep in mind that freezing of gait is also relieved by external factors, which Miriam will talk about, which are auditory, tactile, and visual cues that can bring the focus back to gait and overcome some of these challenges. This next video shows you some of that in that same patient. This video, by the way, does not have any sound. So in this, you can see in this patient now, with these visual cues on the ground, the blue tape on the ground. He was able to overcome his freezing. This, while you can't hear this, there is an auditory cue being used by the physical therapist here. And so with the auditory cue, the patient again is able to overcome their freezing. So as we just discussed, I hope you can see now how external environmental factors like hazards in the home, again, where falls happen the most, can precipitate freezing of gait. And so here's this is actually a cartoon image of a living room space. This is an image from a booklet that I'm hoping to develop as part of my research that has several of these environmental fall risk factors numbered. And some of those include uneven ground, obstructions and obstacles, poor lighting, unsuitable furniture, like this chair here that's broken. And also, as you can see in this cartoon image, excessive furniture. So you could see how the sofa and the chair and the coffee table are so close to each other, right? So really a patient has to maneuver through this small space in order to maneuver through their living room, which that tight space can definitely bring out a freezing of gait episode, thresholds, and then finally, two things that are not necessarily pictured here, but entering a new environment is also a challenge to gait, and then being rushed in the setting. So many Parkinson's patients are rushing to their appointments with their doctor and trying to rush in and out of the elevator, and those circumstances can be anxiety provoking and bring out freezing episodes and increased fall risk. The last point I would like to make is that before I turn it over to Dr. Rafferty is this is a common figure we show all of our patients, which kind of demonstrates all of the different symptoms that patients with Parkinson's disease can have. And as you can see here, falls is actually mentioned late in the disease, but I would argue that as soon as someone is diagnosed with Parkinson's disease, and as soon as they are manifesting with bradykinesia and rigidity, as I discussed, there is a risk of falls. And so from my perspective, fall prevention should start early. And by starting early, you can really cement these concepts, both yourself and your care partner, and ultimately that will bode well for you. And then another point that I wanted to express to you with this figure is that fall prevention is kind of a moving target as Parkinson's disease advances. You have different symptoms that come into play, and as your Parkinson's disease changes over time, your therapeutic needs are also going to change over time. What may work at one point in time with respect to rehab early in the disease may no longer work later in the disease. So it's important to keep that in mind, important to realize that creating a nice partnership with a physical therapist can help you keep up with that moving target. And so with that, I'd like to turn it over to my wonderful colleague, Dr. Rafferty, who's going to be discussing rehabilitation for fall risk.
Thank you, Dr. Afshari. You really set up my talk super well, and I have to thank my colleagues here at Shirley Ryan Ability Lab, Jennifer Barber, Caitlin Suchek, and Talia Shapiro, who all have contributed to fall presentation materials. I am primarily a researcher at this point in my career with funding related to physical therapy for Parkinson's from the Eunice Kennedy Shriver National Institute on Child Health and Human Development, as well as the Parkinson's Foundation. And while my research doesn't focus on falls specifically, pretty much all of PT, as Dr. Afshari said, has falls in the back of our mind. Regardless of the stage of Parkinson's, we're always thinking about walking and balance and the potential for falls. Next slide. So I'll be talking more about physical therapy and evidence-based approaches in PT as well as other rehabilitation disciplines. So as Dr. Afshari said, both internal and external factors can lead to falls, and thus our strategies in physical therapy and rehabilitation also address these internal factors and external factors. In the top box, you see some of the things that we can do to help address internal factors that are affecting your fall risk are working on your balance specifically, working on improving walking, which in walking is a dynamic balance task. We can work on mobility training. We can work on to improve strength, and we can work to improve bladder function, which sometimes is a contributor to falls, especially in the evenings or at night. We can address cognition and dual task training because distractions can sometimes lead to falls, as well as just self-management in general. External factors that we address in rehabilitation include identifying compensatory strategies that can make you more safe. This might be using an assistive device or another tool to make an activity that you're doing at home more safe. We can address home modifications and a safety evaluation of the space in your home, and we can work with you and your care partner with education and training. So Dr. Afshari mentioned how important it is to think about falls throughout the continuum and how what you do in rehabilitation might change early in the disease process versus later in the disease process. And in physical therapy, we put that in 3 buckets. One of them is proactive care. Before you've ever fallen, before you even feel like your balance is impaired, what can we do to help address your fall risk? We assess minutely your walking and your balance. And if we find any deficits, we want to nip that in the bud before it becomes a problem rather than waiting for it to become a problem. If it is a problem, if we do notice a change or a deficit, we do what we call restorative rehabilitation. And this is where we're trying to improve your function or help you get back to where you were before. In the later stages of the disease, but really we're thinking of it throughout too. We're thinking about how can we support you and your family to have the best, highest quality of life, which includes safety and helping to protect yourself from falls or preparing in case a fall does happen. So again, through that continuum. As I said earlier, I'm going to kind of walk through a few different interventions, mostly here focused on balance, walking, and mobility training to address those internal factors and what we think of restorative PT, but keep in mind that you can work with rehabilitation professionals for a variety of factors. Next slide. So the American Physical Therapy Association put together and published physical therapy guidelines for how physical therapists should manage Parkinson's disease. These guidelines mostly focus on restorative PT, and what they recommend is that your physical therapist should use the following interventions, depicted kind of as pills, these oval pills, to address walking, balance, and mobility. If you want to address a balance problem, you should do task-specific balance training. So if you're concerned about balance and you are focusing your exercise routine on stretching, it's unlikely to have an effect on your balance. You want to focus on balance training, gait training, and it's important to note that this rehabilitation could be in person, but also can be delivered online through telerehabilitation or telehealth or online exercise programs. For walking, I'll talk about a variety of techniques. The most important way to improve walking function is to practice walking, but we need to practice walking in an appropriately challenging setting. If it's just like a leisurely walk, walking the dog, it's unlikely to change anything. So you really have to push and do gait training or walking training. Balance training can also improve your walking ability, and using external cues and a variety of external cues, as Dr. Afshari talked about with visual cues or auditory cues, particularly with freezing of gait, can also improve your walking. Functional mobility is the third task I'll talk a little bit about today. This is essentially moving from one place to another. A lot of our movements in our house are just standing up, sitting down, turning, walking from one room to another, but not really a very far distance of walking, lifting up a basket of laundry from the floor. For functional mobility, that can improve with exercise. Things like strength training and aerobic training can help you with your mobility in your house. Community-based exercise programs can also help improve and maintain function. And another important aspect here is task-specific training. If you want to improve your stability when you stand from a chair, practice standing from a chair. Next slide. So focusing in on balance. Balance is the ability to stay upright. This is the way we think of it as a PT. Dr. Afshari mentioned that there can be problems with retropulsion or falling over backwards. That is a common problem that can happen when standing statically or during functional mobility, like standing from a chair where your body almost just leans a little too far backwards and so you fall back into the chair. Balance also can be dynamic balance. This is when you're walking and moving around. Anytime you're moving, your body has to adjust to that movement. It has to anticipate. If you pick up something heavy, your body has to anticipate what it needs to do to hold your balance. When you take a step forward, if you're turning, if you're walking in a crowded area or on an uneven surface, your body naturally anticipates what type of challenge it's going to experience there and will adjust for it. Sometimes, though, it's not possible to anticipate that. You might get bumped, especially if you're in a crowded area. You might step on a surface that you thought was stable. In Chicago, where I'm presenting from, this time of year, it's not an issue, but in the wintertime, stepping on ice, you think it's a safe step, but you could be knocked off balance quickly, and that being able to react to that perturbation is a very important skill to develop. So in PT, your physical therapist would talk to you about how you move around your house, what you do as your leisure time activities or your necessary work activities, and they will design a balance training approach designed for you. They'll talk about what and give you home exercise programs that include those balance activities, but they'll also think about compensatory strategies. So at some point in the disease process, you may need an assistive device to be safe. This might be something that you use only when you're outside the home, but not inside the home, or something like that, that because it helps you get out into the world. And so while we want you to be safe out in the world, it's still important to get out and to do things. It's really important for kind of emotional, mental health to stay active in your community. I'll talk a little bit more about that at the end of the talk. And then we also would do some home environment assessments. We would talk to you about where you have tables. We could have you take pictures of your home. There's physical therapists that go to people's homes, occupational therapists as well, that can help you set up your home more safely. Next slide. So I'm going to talk about the 3 P's of balance training here. The first one is to practice. We practice static balance, often using a smaller but safe base of support. For some people, this is standing on one foot. Every time you take a step, you have to stand on one foot. So being able to hold your balance in that position is actually a very functional skill, not just a yoga pose. But yoga and other community-based exercise programs can sometimes provide training using these types of positions. If standing on one foot isn't safe for you, there's other ways that we can help you work on balance, such as putting 2 feet next to each other instead of wide, or practicing putting one foot in front of each other, or your feet kind of a little bit diagonal, and just practicing standing and standing up from a chair with all of these different bases of support. We have you work on stable or unstable surfaces, like walking outside. If you have a current exercise habit or routine of walking outside or going hiking, then you need to be able to adjust to uneven surfaces, cracks in sidewalks, lumps in the grass. And the more you do it, the better you are at retaining that skill. And if you stop doing those activities, you will ultimately lose the ability to react and adjust to those activities. So it's just really important to think about what you want to be able to do and how you're doing it. We need to be proactive, address these things before they become problems, and progress with appropriate challenges. So if you say, it's fine, I'm exercising, I'm already doing this, and I've been exercising my whole life, and you're doing the same routine over and over and over again, it's likely that you might need to change that up over time to help progress and get better. Next slide. And going to walking. Walking in a physical therapy definition is actually a series of controlled falls. Every time you pick up your foot to take a step forward, when you put your foot ahead of you, but in that brief second where it is above the air, so in the first figure here on the left, you lean your body forward, and that front leg, that initial contact, is catching you from falling. And then you pick up your next leg and you lean a little bit, and then that next leg lands and catches you from the fall. So walking is really just controlled falls over and over again. So if you don't step far enough, you might not catch your fall as well. That gets into the festinating gait, where you lean forward, but your step isn't big enough to catch you as you move forward. Or freezing of gait, if you're not picking up your leg and moving it forward, you're not going to take a step or catch a fall. So this is how walking and balance are so intimately linked together, is because walking is really controlled falls. Um, so just if you have that in mind as you think about your next time that you're out going out for a walk, hopefully that will help you think about it the way a PT does. Next slide. The way that we practice gait is we practice first, we want to just have you practice doing steps, taking bigger steps. We do this over ground, and we can do this on a treadmill as well. Treadmills are kind of nice because they don't let you slow down. So while many people with Parkinson's have this natural habit to start taking slower steps as they walk, the treadmill will keep you going, and that can help your body kind of learn that cue of taking larger steps. But ultimately, you do need to practice that over ground. You need to practice it with straight line walking. You need to practice it with turning. You need to practice it in tight spaces or with variable stepping patterns. Like if you walk into your kitchen and get something out of the refrigerator, you are probably making a turn. You're then taking a backward step. You're then taking a forward step. As you close your refrigerator, you're turning again. So you have to have that ability to lean your body and move a foot and catch yourself in all different directions. When we're in physical therapy, we're going to work you hard. We want to push you to the edge of where you are safe. We use equipment like safety harnesses, or gait belts to help find out where that edge is. And then we want to practice at that place to help you develop more, better walking skills. If you are at a point where that is not safe anymore, that's when we start to look towards assisted devices, and that balance there between improvement and compensation is something that we're always thinking about. One of the strategies that we use a lot in this space are external cues. The first external cue that you learn from a physical therapist is focusing your attention on your walking. It's not as automatic as it used to be, so you have to think about things like big steps. Then we can do auditory cueing, like listening to music or a metronome, just to help train that automaticity or rhythmic gait again. As the disease advances and you have problems with certain spaces, like going through a doorway, practicing identifying visual cues and giving you something to step over is something that can help, particularly when it comes to freezing of gait. And then now with the advances in technology, there's a lot of mobile devices or things like watches that have metronomes built in, where if you're the type of person who kind of gets annoyed at hearing a metronome clicking in the background, you can set your watch to buzz in a rhythmic pattern. So that's called a tactile rhythmic feedback. So there are lots of different cues that we can try out in physical therapy, and I wish I could tell you which one is the best, but it really just depends on you, your background, your situation, and all of those things. So now finally, I'm going to move on to mobility and strength. And the reason I put strength here with functional mobility is that really moving around your house and all those tasks like sit to stand require strength. You have to stand from a chair, standing from a lower surface like a sofa or a toilet. Getting into and out of bed requires a lot of core strength and flexibility. Lifting something, whether it's symmetrical like a laundry basket or asymmetrical like a gallon of milk, all of these things require strength. So when we do these more basic tasks with you, as well as more advanced tasks, stairs, ramps, kneeling and getting up from kneeling, playing, being able to get down on the floor to play with little children, or longer term endurance to go out into the community, we're thinking about fitness. So aerobic exercise, strengthening exercise, and thinking about these more functionally. So it's not just walking on a treadmill. We want to try to address how that skill is functional for you. We'll do task-specific training here as well. So just like walking practice improves walking function, lifting practice improves lifting function. Turning practice improves turning function. Often when we're thinking about these activities of daily living or advanced activities of daily living, we're thinking about how do we keep you doing the things that you want to do. So this could be assistive devices, caregiver assistance, and just trying to help maintain your roles in the world and the things that you like to do, because those are really important for quality of life. We want to help keep you independent and safe at home. So thinking about grab bars in your bathroom, removing rugs, so that your feet are less likely to get tripped up on something, and thinking about putting objects in your home that you might need to reach a lot in the kitchen on lower shelves so that you're not having to stand on your tiptoes or reach like way out to the side. So those are all things that your PT as well as some of your other rehabilitation professionals would be working with you on. Next slide. So speaking of those other professionals, the other people on your rehabilitation team include other physical therapists possibly, as well as occupational therapists, speech therapists. There's a field of physical therapy called pelvic health PT, and they can really address some of the issues with urinary frequency and urgency, particularly that might make you feel like you're in a rush to get to the bathroom, or that are waking you up at night and making you need to get up quickly. Those are things that are skills, and they're tips and tricks that our pelvic floor PT colleagues really know well. PT, OT, and speech all work on dual task training and functional cognition types of tasks, how to plan ahead to make sure that you're putting yourself into safe situations. And we all, in our different roles, address self-management, compensatory strategies, home modifications, care partner training. Our medical rehabilitation professionals, along with our medical teams, including dietitians, will think about nutrition and hydration because dehydration can lead to low blood pressure, which can lead to a fall, and medication management is also very important. Next slide. And finally, before I close, I did want to mention something about that anxiety that Dr. Afshari mentioned as well. One of the things that we're doing in PT is measuring your actual balance function and trying to match your balance function to your fear of falling. Fear of falling can lead to more immobility, reduced physical activity, which then can lead to more deconditioning, which then can lead to more walking problems, which then can lead to another fall or your first actual fall. So we want to look at your fear of falling and your history of falls as well as your current balance function to see whether or not your fear of falling is a real fear and that it's placed well, that you have appropriate caution when it comes to your activities. But we sometimes also see that the anxiety and non-motor symptoms of Parkinson's can lead people to have more fear of falling, even when their physical balance function is not as bad. And so then we want to try to help make sure that you don't have misplaced fear and that you understand where your limits are and your safety is so that you don't cut back your activity too soon. But we also want to make sure that you are appropriately cautious if you need to be. So what next? First, if you haven't gone to a physical therapist lately, you could ask your doctor for a physical therapy referral. Be proactive. It's not too early to start. Prevent falls if you can. There are exercise techniques and community-based exercise programs that have been shown to reduce fall risk. Identify compensatory strategies that will help keep you safe early. Prepare for a fall. As you'll see in our next few slides, Dr. Afshari will walk through how you can think about falling safely and returning to stand. And progress your exercise routine. The same exercise routine for over a year normally is not good enough. You're going to need to change it up every once in a while. And ask about other rehabilitation providers. Your PT could give you advice. Your doctors could give you advice also on whether you could utilize pelvic floor PT, OT, particularly for home and environmental modifications, speech language therapy, or neuropsychology.
Thank you so much. That was so excellent, Dr. Rafferty. So bringing it back to things that we've mentioned this a couple of times in the presentation, that we want to also teach you all how to fall more safely. And so this was coming from feedback that we received from one of our patients. We decided, myself, Dr. Rafferty, and one of the wonderful physical therapists that she works with, Jennifer Barber, we decided that we should really also educate you on how to fall more safely and how to get up from a fall more safely by creating a video. And so I wanted to show you parts of that video. As you saw, we obviously want to prevent falls. We want to reduce those numbers that I quoted early on in the presentation, but falls are unfortunately inevitable. They will happen. And so let's see how we can fall more safely. So I'd like to play this video that Jennifer Barber was able to help create with us and she's in this video, she's able to demonstrate different types of falls, falling backwards, falling sideways, falling forward. And she points out tips to help you reduce your chance of injury during those falls. So I'm going to go ahead and play this video for you all. Hopefully you'll be able to hear the volume, but if not, we're going to be circulating this video in the upcoming weeks on the Parkinson's Foundation website and other forums as well. Oops.
I'm going to demonstrate how to fall backwards from a standing position. So first step, we're going to want to get it as low to the ground as we can in almost a squat position. We're also going to try to round our upper body and then tuck our chin to protect our head. From there, you're going to roll backwards onto your bottom and then your back, and then put your arms out to try and help disperse that impact over a greater area. We're actually going to start in a sitting position. From here, again, we're going to round our upper body, tuck our chin to protect our head, and then you're just going to roll backwards, putting your arms out to disperse that impact. Now I'm going to show you how to fall safely sideways. So what we're going to do is from standing, just like backwards, we're going to get as low to the ground as we can in that squat position. From there, we're going to try to thread the needle with our arm closest to the floor, and then we're going to roll all the way over to the other side. We want to make sure that we continue rolling and not just stop the movement so that we can disperse that impact. We also want to make sure that we land on those fleshy parts of our body, so the upper arm, the bottom, and the thigh. So now I'm going to show you the modified version of how to fall sideways. So we are going to start on our hands and knees. From here, we are going to tuck our chin again to make sure that we're protecting our head. We're gonna thread the needle and bring our upper body close to our lower body so that we reduce that initial impact. And then we're gonna roll all the way over. Now I'm gonna show you how to fall safely forward. For this direction, we're gonna start in our standing position. If you can, you're gonna try to take as big of a step as possible to try and get as low to the ground as you can. From there, we're gonna go ahead and land on our forearm and our open hands to disperse that impact and minimize risk of fractures. From there, we're gonna go all the way down under our chest, slide your arms out, and then make sure that you turn your head to the side so that we protect your face from facial injury. Okay, so now I'm gonna show you how to fall forward in a modified version. So we're gonna start in the kneeling position. We're gonna land on our forearm and open hand, and then we wanna make sure to turn our head to the side to minimize risk of facial injury. So from kneeling, we're gonna fall forward and make sure to turn our head. So now I'm gonna show you how you can fall safely forward if you start to festinate, as we know that this is a common symptom for individuals who have Parkinson's. So if you get into that festinating pattern where you're taking those really quick steps and you're not able to take a big step to get down, what you can do is come down to your knees. And then from there, as we practiced before, come down onto your forearms and open hands. This again is going to help minimize the risk of fracturing your wrist. So from there, we're gonna go down onto our forearms, open hands. Make sure you have your head to the side so that we minimize risk of injuring your face, and then slide your arms out.
So just to recap, I hope you were able to catch some of these tips in the video from Jennifer. Here's just a recap of some of the things that she mentioned. To protect your head, you want to tuck your chin down and really bring your head as close to your body as possible during the fall. To avoid a wrist fracture, it's important to try and fall on open hands and forearms rather than locked hands or extended wrists. Falling on the more cushioned parts of your body, like the upper arms, thighs, and bottoms, will also reduce your risk of fractures. Important to maintain that cushion, and discuss with your doctor about how to maintain your muscle mass. When falling forward, you want to try and turn your head to the side so you can minimize facial injury. When falling in any direction, this is a really good one. You do want to try and get as low to the ground as possible, which might mean you have to squat like we saw in that video, or you have to lunge forward with your stronger leg, because getting as low to the ground as possible initially is going to reduce the impact and the bluntness of your fall. And then finally, if you can roll into the natural direction of your fall, I believe Jennifer was able to demonstrate that when she thread the needle and rolled all the way through, you're really going to reduce the overall chances of injury from the fall. This next video, after a fall happens, how can you safely get up? Before I play the next video, I think it's important to mention that if you are injured from a fall, you suspect that you're injured, try not to get up on your own. If possible, try to get help before getting up. And to err on the safe side, it's really important for you to see a doctor, go to an emergency room after a fall, really to make sure that there's no brain injury or fractures that may seem silent at the time, but can escalate over the next 12 hours. So in this next video, Jennifer is going to demonstrate how to safely get up from a fall.
So now we're going to go over what you should do after you have the fall. So first and foremost, you want to make sure that you assess the situation. Make sure that you are not hurt and that you're able to get up safely. It's also best if you can have someone assist you just to make sure that you're safe. So first, what you want to do after you've assessed the situation, you want to try to scoot yourself to a supportive surface so that can help you. From there, if you can, we want to try to get on to hands and knees, and then using your supportive surface, you can go ahead and come up into a tall kneeling position. From here, I typically will recommend stepping forward with your stronger leg, because that is the leg that's going to do most of the work. From there, we can do one of two things. We can come all the way up to standing using that supportive surface, or if your supportive surface is like a chair or a couch, you can just scoot your bottom onto that chair or couch. Now, if you have a care partner who can help you up and assist you, it's best, if you happen to have a gait belt on, it's best for them to help guard you and help you by using that gait belt. If you don't, they can kind of hold you around the waist or the belt area to help you into each of those positions. You want to make sure that they avoid grabbing under the arms because we don't want to injure the shoulders.
All right. As Danielle mentioned, we're going to be creating a full video with all of these clips and some of these tips that I mentioned, and we'll be sharing that with you through the Parkinson's Foundation. So that brings us to the conclusion of our presentation. Thank you so much for tuning in, and Dr. Rafferty and I are happy to take any questions.
Thank you so much, Dr. Afshari and Dr. Rafferty. I wanted to address this question that came in. It's very relevant to just the videos that we just watched. And this question came in from Michelle, and she had mentioned that it's very hard as you're going through a fall to remember you need to crouch, you need to tuck your head in, thread the needle. What are your recommendations to try to really hone in these key points so that if a fall does happen, right off the top of the head, they need to remember to do these certain things?
I can take this one. As people's Parkinson's becomes more advanced, it is really, really tricky. And so what we don't know as physical therapist is whether all of the things that we're hoping that we're sharing here, like preparing for a fall, learning these strategies, we're hoping that if we can teach some people these things earlier in their disease, that they may develop them as habits for later. We don't know whether that will work or not. That's research still that needs to be done. If you're already in late stage disease, and especially if there's cognitive deficits, it would be almost impossible, I think, to pull those strategies out. There are assistive devices that are out there that can help keep your husband or your loved one safe in these moments. There are head protectors, there are helmets, or there's hats that are padded that people can wear if they're willing to wear them. Again, I don't know if I can recommend one particular brand, or I can't recommend one particular brand, but it's something that you can look into. Home modifications there's they make for children like bumpers to put on coffee tables so that the corners aren't so sharp. Those things can also be helpful in a situation with older adults who might fall and hit their head on a piece of furniture. In Europe, they have these really cool airbag bike helmets. So, if you don't want to wear a helmet all the day, it's like kind of like a necklace, but that if it detects a fall from a bike, it would kind of create a helmet. I would love to see something like that tried out in Parkinson's. Maybe the Parkinson's Foundation can help us fund some research in that space, because it is hard to have people wear a helmet all day. But this is where assistive devices and compensatory strategies are what we would move to.
Yeah, I would agree with everything you said, Miriam, and I think one thing that you honed in on was during your presentation was practice, right? Practice, practice, practice. And at some point, like you said, some of this is going to become muscle memory, even if it's just the tucking of the chin that becomes muscle memory. That in itself can save such a grave injury, like a head injury, and will really prevent you from having a serious fall.
So it sounds like practice makes hopefully things a little bit better for if the time comes. Trying to do home modifications if possible, or even I think Dr. Rafferty, you had mentioned that maybe an occupational therapist can help do a home assessment, whether it's virtual or actually coming into the home and trying to look at potential fall hazards. So really trying our best to prevent a fall from happening, but also being aware of these certain cues for if the time comes and you do fall down.
Yes. And if any of you do try out these airbags and newer technologies, please let us know what happens and whether they work. The risk with them is if they identify a fall when you haven't fallen, you'll get this like blow up airbag around your head, or they have hip protector ones like that too. And I do know that there are researchers that are looking to develop algorithms for Parkinson's disease. But right now it would be more of an anecdotal evidence. So let us know what you find out.
Great. And so for time's sake, we just have time for one more question. And I think this one came in. It's really about post-fall recovery tips. So thinking someone just fell down, maybe they had to call emergency services, or maybe it wasn't to that extent. What's the first, what should they do? They've assessed the situation, it's safe enough for them to get up. Should they be calling their doctor and letting them know they fell? What are sort of these immediate steps that should be done?
Yeah, I think I can take that one. I think, like I mentioned in the slide, some of these injuries can be silent at first, especially injuries to the head. You don't necessarily have to hit your head in order to have incurred an injury. Unfortunately, as you get older, some of the cushioning in your skull is not as great. And so you can kind of rip vessels that cover the inside of the skull, and that can lead to a bleed. And it can be a small bleed, but with time, that bleed can expand and can have grave consequences. So, from my perspective, I think it's really important in any type of fall to really just go get checked out. It's better to be safe than sorry. If not going to the emergency room, I would at least call your doctor, and they can order a quick head CT that can be done very quickly. It's kind of like an X-ray of the head that's done within 5 minutes, and it can rule out a big bleed in the brain, rule out kind of those gross injuries that can happen in the brain. And then you can also just like the head injury, you can also incur a fracture. And fractures can also grow over time. And so it's important to get it. If you've fallen on your hip, as you mentioned, hip fractures are the most common in falls. Getting an x-ray of the hip to make sure there's no silent fracture there that can worsen over time. I think that's super important. That can be done as in the emergency room, obviously, but it can also be done as an outpatient with your doctor.
Thank you so much. And Dr. Rafferty, I know you have a hard stop, so feel free to jump off. But thank you both so much for providing just your time, your expertise for today. And for anyone whose questions we weren't able to get to, please know our helpline, 1-800-473-4636, or helpline at parkinson.org. They can help answer any other questions that we may not have been able to get to, just given the time. So again, thank you, Dr. Rafferty, Dr. Afshari. Thank you, Jenny, the physical therapist who did the demonstrations for the video. As a reminder, today's program was recorded, and we will share everything in a follow-up email, copy of the slides, a summary, as well as the videos that you had seen. We'll try to fix the audio so that it's a little bit louder. So apologies for that, but you'll get all of that in a follow-up email, so just keep an eye out for that. We have a few more resources on fall prevention and moving safely with Parkinson's, all on our website, parkinson.org. Again, we'll share these links in a follow-up email as well. You'll also see a video here, and this is the webinar that we had Dr. Afshari do for us last year on Gait and Balance. So if you are interested in looking at that, it'll all be included in the follow-up email. Thank you again to the Light of Day Foundation, whose generosity has made this programming possible. Thank you so much for joining us today, and we look forward to connecting with you at our future programs. Take care and be well.